So thank you so much to everyone for joining us for today's webinar. We will be discussing the business behind the vaccine. So we'll touch base on the economics, supply chain, and the policy surrounding the vaccine, and a lot more than that. There will be time for Q&A at the end of the webinar. Feel free to drop a question in the chat at any time too, and we'll see if we can get you an answer in real time as the discussion is going on. Let me go ahead and introduce you to our panelists. Balazs Zsenits, MD. He is the Chief Medical Information Officer at Rochester Regional Health. We have David Krusch, MD. He is the VP of Applications and a surgeon at Rochester Regional Health. Matt Phillips, EMBA, is the VP of Health Informatics at Rochester Regional Health. And John Striebich, MBA, is a Macroeconomics and Finance Professor at Rochester Institute of Technology. I'm going to go ahead and hand things over to Jeff Davis, EMBA. He is the Director of EMBA and Executive Education Programs, and he will be our moderator today.
Thank you, Jessica. Welcome, everybody. We had some people come from Rochester Regional Health last year to talk about some of the things going on with the pandemic at the time. And this is a more up-to-date current event about what's going on with the vaccination. And I know that when I talk to people, there's a lot of interest in what's going on with the vaccination. Originally, right, we heard that there was going to be 20 million doses prepared in the US before the end of the year, which would have been December 31st. And that we intended to have 20 million doses given by the end of the year. And that didn't happen. It didn't come very close. And I think most people assumed that it would be very easy to get this out, right? We get 300 million doses made and we can get 300 million shots given and we'll all be taken care of. And it's not quite that simple, obviously. And we're going to talk a little bit about what's going on with the vaccination, where it is right now, and some of the specifics as we go. So I want to talk first. I'm going to go out to John Striebich first. And John, I want to ask you a question about the supply chain itself. You know, we called this the largest product launch the world has ever seen. And it is a pretty amazing undertaking that has happened. And there are things out there said, and there are concerns about the process and how it's happening, and is it happening well? And in fact, it's never happened this fast ever for an immunization to take place. This is a pretty unbelievable undertaking. Getting a vaccination through the process of medical approval and to where we are today and to have it going into arms is a pretty amazing thing to take place. But there are some challenges and there are some difficulties in trying to achieve what we're doing. So we know that when the pandemic started, we had trouble getting toilet paper. We had trouble getting Clorox wipes and you know, Clorox spray and other things. I'll tell you, my strangest one of all, crushed red pepper. I don't know why that became a pandemic item, but I couldn't get it for a month or two. Things happened in a strange way, and we saw the supply chain really stretched in a lot of ways. So it makes us wonder with the vaccination, those are not very complicated products. And the vaccination is a much more complicated product. So tell us a little bit about what's going on in the supply chain and what some of the challenges are in getting this out to everybody in the United States.
Well, Jeff, you know, to your list there, you can even add flour as more people baked during the pandemic. So, I mean, it was some of the basic things. So, I mean, the supply chain, you know, we've gone back to, you know, the beginning of the pandemic to talk about supply chains. And you're right, it started with toilet paper and different things like that. And now we have this supply chain that was put together rather quickly to try to get the vaccine out to individuals. And, you know, a chain is really only as strong as its weakest link. And so there's some weak links in the supply chain. And in fact, I would even go to the beginning and say that there's some design flaws in this particular supply chain. So you're right, let's talk about some positives. Okay, we manufactured the vaccine in record time. Okay, it was tested, it went through the different FDA protocols. The FDA approved it really quickly. So we had some really positive events happen, and the delivery of the vaccine to the different states and localities happened pretty seamlessly. And, you know, you got to give kudos to UPS and FedEx for that. But what's fallen apart? Well, what's fallen apart is the plan. And again, when we're teaching business, in almost every course we teach, we talk about planning. And the planning fell apart at the beginning because you didn't link the chain up. And the real problem was once the vaccine is delivered to the localities, states, counties, departments of health, local healthcare systems, even pharmacies, the issue was that there was really no plan to assist those units to actually get the vaccine out, because it's not the federal government that's going to put the vaccine in arms. It's going to be a local presence. And so even the general who was in charge of Operation Warp Speed, General Perna, has come out and said that that was a huge flaw, that what they concentrated on was manufacturing and delivery of the vaccine to the localities. What they didn't provide these local units, like the hospital systems, is a real good direction. There's really not a lot of what I would say consistent communication. There's no financial resources that have been involved with this. And really, it's only lately that you've seen, the states set up, massive testing centers. Finally, the Monroe County Department of Health is out there looking for nurses to hire to do the shots. I mean, some of the basic, ground zero types of things that we needed to do were sort of left out of the planning. They figured we manufacture it, we deliver it, and they come. And yes, they've come, which is the individuals that want the shot. And in fact, they even added another really bad wrinkle to this whole thing. They thought that there was an issue with not enough vaccines being given to people. I mean, the data shows there's 30 million doses of vaccines distributed and about 12 million actually given throughout the country. So they thought that in order to get more of the vaccines distributed into people's arms, let's open up the population. And in New York State, that's called phase 1B, where now people over the age of 65, people with pre-existing conditions, and essential workers now were thrown into the pot. So demand now is really a lot higher than supply.
Thank you, John. And actually, it's interesting that they've expanded in a lot of places who's eligible to get the shot when they haven't necessarily had the doses available for those expansions. And different states have done that very differently. I mean, I know I heard in New Jersey, pre-existing conditions would put you up on the list, and one of those pre-existing conditions was if you were a smoker. So that was a controversial decision that was made by New Jersey, and each state had the option to make their own rules. So for example, in New York right now, faculty teaching in colleges face-to-face are now in category 1B, are eligible to be vaccinated. In Massachusetts, that is not the case. It's K-12 only for that. So state by state, they've had to make those decisions, and they've been very different from state to state. With that in mind, Balazs, I was hoping to ask you a question then about this issue of the federal government handles getting the vaccines out to the states, and they choose how many and where they're going to go to and how they're going to get them out, and they lay some guidelines out there. And by the way, I think there are even some requirements that the eventual people handling the shots have to hold to, or else they have fines available to them. There are challenges ahead of them for that. But the federal government gets it out to the states, and then the states get it out to their local places, and that tends to be hospitals and pharmacies and frontline places. And yet there's no manpower associated with these steps. And so the manpower seems to fall all on the people getting the vaccination. And this is at a time when you're seeing an uptick in cases, an uptick in hospitalizations, an uptick in ICU beds being occupied. And yet this is the heaviest portion of the vaccine rollout right now, where you've got to come up with people to do this, to run these clinics. So can you tell us a little bit about that process?
Yeah, I mean, on the macro level, this shows kind of a uniqueness and weakness of the American healthcare system, as the federated healthcare system with the federal government giving it out to states. States regulate their hospitals. Hospitals are trying to distribute this first to the employees and then to the population, but nobody actually has strict control of the process. And as you know, in a crisis, the best way of managing a crisis is to have a strong central leadership that provides clear guidance and feedback to the on a chain of command. That doesn't really exist here. and you could have seen that. I mean, you must have seen that in the media as people were pointing fingers to each other what happened. But this is not an occasion to blame one another. But this is just a reality of life, how the American healthcare system is organized, and the country is run. The most insight that I personally have and what we have is really what happened at the ground level when we finally received the vaccine. And as you pointed out, the administration was really not very well thought out, and people just assumed that we're just going to do it. And that actually did happen. But you must understand that these hospitals that received the vaccine for administration had the biggest crisis that they were facing outside of vaccination. Testing itself for COVID testing was a huge amount of endeavor for labs, personnel, the IT teams to build it, to report it. But and obviously it was the biggest surge that we have ever seen. Hospitals were opening new floors every week, trying to spread their personnel as thin as possible, getting new ventilators, setting up new systems. We expedited opening our SAN Constellation Critical Care Center by several months and filled it up very quickly at Rochester General. So this was a time that there was huge competing priorities that we received at. And this is not an excuse, but this is just the planning that we mentioned earlier. And Dave can talk about what actually it took, even from the IT's point of view, to do this vaccination. We had to build vaccine clinics. We had to comply with regulations that changed week by week. We face penalties of $1 million if we give it to someone that doesn't meet the vaccine criteria, but $100,000 if you don't give it to someone who meets it. And at the same time, receiving the vaccine is a voluntary exercise. And just like in the general population, what we found that about 75% of our employees are willing to get the vaccine, but there was also not a unified political message about the importance of the vaccine. So, it's no secret that this is a time of multiple crises, and one of them is credibility and trust, and that certainly made it even more difficult. Now, all that said, I think we did a very good job in vaccinating our employees, whoever was willing to get the vaccine. And again, I think Dave can give much more details what actually happened, what IT tools and labs we set up, how we ourselves will volunteer to actually give the vaccine as we receive it. And I think he may be the best person to describe, because he spent 300% of his time, to quote him, on this project over the past several weeks.
Thank you, Balazs. And David, I will come to you now, because I'm curious about a couple things. Number one, we heard that it went pretty well getting it out to healthcare, and that must have been an enormous challenge, because my understanding is that you couldn't get people in the same area work-wise vaccinated at the same time. You had to balance that out a little bit in case there were side effects or problems, and you had to give thought to that process. But also, you managed to get most of the people vaccinated. And in healthcare, we heard numbers that some people within healthcare were not ready to get the vaccine. And so I'm curious if you can share information about that as well.
So Jeff, thank you. So I think what Balazs highlighted is the governmental constraints, and a lot of the foundational problems of dealing with a mass initiation of something that we don't necessarily have an infrastructure in place for. So the first thing is, remember, everything we're going to talk about having the right infrastructure in place is going to be constrained by everything that Dr. Zsenits talked about. And one of the things that Dr. Zsenits has talked about is the regulatory constraints. And the regulatory constraints have been in flux. I'm choosing my words diplomatically. So what's 1A? What's 1B? What are the regulations regarding what populations you do? It started off very clear and crisp that we were doing 1A, frontline healthcare workers, and you needed to divide it into priority groups, and you needed to divide it, Jeff, as you said, into pods. Well, what was a pod? Well, if you had, imagine, 100 healthcare workers on a particular unit, you only wanted to do a third at a time. So 33 on one day, 33 maybe 2 days later, and 33 maybe 4 days after that, because you didn't want to take the risk of having a particular population of healthcare workers that are staffing a similar patient care delivery area have side effects all at once. Well, with the first dose, I think the side effects early on in the process, it was recognized that the side effects of the first dose were probably not the rate limiting factor. So this type of pod gating mechanism, I think rapidly became less than essential. The other thing was, what's the infrastructure? What's the boots on the ground? When we think about mass vaccination programs, we do very well with our maintenance vaccination programs in offices for children and adults, DPT, meningococcus, and all that stuff, because for two reasons. Number one, it's done on a gradual maintenance perspective over time. Number two, the product itself is relatively easy to store. In contradistinction, this was a mass vaccination program with a product that had certain storage constraints. For instance, the Pfizer vaccination had to be kept at minus 90 degrees. And once it was thawed, each vial that was thawed had to be reconstituted. And once it was reconstituted, you could get 5 or 6 doses, but it was only good for 6 hours after that. So you had a constraint based upon storage. You also had a constraint based upon the fact that you were doing everyone all at once. So it's far from what we would call a maintenance program for immunization. And what was available? Dr. Zsenits talked about a staffing constraint. Well, what about the sheer infrastructure? Are we going to say everyone in your office and you're now going to be delivering it? That's probably not the right infrastructure to deliver it. So we had to stand up things that were not necessarily in place. We had to stand up areas for mass vaccination. You've seen Monroe County stand up the Dome Arena. Well, that is for, mainly speaking, your 1B population, which started as 75 and older, and then it changed to 65 and older. Well, how do we manage the same thing, both for our employees and for our patients? We had to create net new infrastructure, both from an IT perspective, a physical perspective, a networking perspective, and a manpower perspective, and in a very short notice, in a very short period of time. So standing that up and then not having had the chance to test it means that you're kind of, for lack of a better term, you're building the airplane as you're flying it. The airplane is flying. It's going to come into a very smooth landing, but it's not like there hasn't been a little turbulence along the way.
Yeah. So thank you very much for that. And I think Matt might add a little bit to both of those questions if he has a chance.
Sure, and I've been kind of, if you see me glancing to the side, it's my other screen because I'm watching the questions come in. So I'm not going to speak to the long-term side effects. I'm not a medical professional, but I will answer, the how do you sign up? I think that's also part of the challenge, part of the constraints we have. So you have competing priorities, right? You need the vaccines in order to sign people up. So we need to make sure that we have the vaccine available to have a sign up for that. On top of that, you have the health system reaching out to our patients as opposed to the patients reaching out to us as they become available. We've had to randomize it so that there's no preference or anything seen. But then on top of the health system, I think someone posted in there the New York State, the NewYork.gov coronavirus or vaccination website. And, I can speak from semi-personal experience. It was through my wife that, that site is just flooded with requests every day as people want to get the vaccine. So the instant something becomes available, you check it and it's gone before you can even get it. So she had to go out a few weeks into available appointments and luckily got one. But even that now, they're withholding future appointments until we can get further vaccines. So it's really, I think the other challenge is if you want to max vaccinate, it's getting the ease of access out there to people. And right now it's got people trying to hunt for it. I can speak as a health system. We are doing our best to try to get to our patients and through our patients, but we're limited by what the supply is. Likewise, the county and others are. And then hope I don't know the answer to that question, but I think reluctance in general is a huge challenge, not just in minorities or other groups, but reluctance in general. And in our health system, that's the other facet too. So if you do have vaccination available, encouraging people to get the vaccine. There was another one, do we require it for our employees? We don't require the flu shot. We don't require this. we strongly encourage it. We track it by data.
In fact,
And-
Matt, let me add to that for a second, because the actual, I believe that since this has been approved through an emergency use authorization, that it's not allowed to be made mandated. That because of that, there is no, anyways, that's the reason that you can't.
Yeah, I mean, I think as a health system, it's been our stance that we don't typically mandate such things like this in the past, even with the flu vaccine or other things. I mean, if you didn't get the flu vaccine, pre-pandemic, anywhere you were in a patient-facing setting, you'd have to mask up. I think now everyone masks up everywhere, but that's kind of how we approached it. And I think much like the flu, we want to track how many people have taken it. We have analytics on that. So, it's even going to come into question, when do we open general office spaces? If, only 90% of the employees take it, do we decide to open up an office building? We have a large, big office building in Irondequoit. I don't know that I'll see that anytime soon. So I think there's a lot of logistic challenges, not just, I'm kind of tying it all together. I know I kind of jumped around with the questions as I've been seeing them, but I'll tie it all together in that, you have supply constraints, and not an easy way for people to be aware of how they can get it. Those that want to get it, a challenging way to reach out, or versus waiting to be reached out to acceptance or reluctance on taking a vaccine that came at a pretty record pace. I'll put this plug out there, and this is a personal statement, not a Rochester regional statement. The instant I can get that shot in the arm, I'm putting it in, but that's my personal preference. So
thank you for that. And I'm going to go back to the question about reluctance, because I actually saw some data on this, that there was a poll advertised by the CDC that said that 74% of people above the age of 75 have said that they're willing to get the shot as soon as they can get the shot. But only 52% of those between the ages of 45 and 64. Now, this poll was done in December, so it's a little bit outdated already, right? Things are changing quickly in this space. But it is interesting that there's still reluctance out there. And maybe that's tied to the fact that it was such a quick vaccination that people just don't know. And let's not forget that in America, we have people that are against vaccinations, even when we know that how truly positive the effects of those vaccinations can be. So it's not unusual or surprising to see that would happen, but certainly in this one, it went through very quickly. And so there's some concern and some questions around that. And then there was a question in here that I want to tie to this, to the other thing you mentioned. You talked earlier, I think it was David that was talking about how you take the doses, you have them frozen, you have to bring them out, you have to reconstitute them. And then when you're giving immunizations, what happens at the end of the day? What happens when those doses that have been thawed and have been used and there are leftovers? Because people are saying here, is it true that New York State actually didn't meet numbers and that there were doses discarded as a result? Can you tell us a little bit about the process and how that works with these?
Yeah, was that to me or Dave? Sorry.
Who's got that information?
I can speak to it from a non-IT side real quick, if Dave's okay with that.
It's all yours, man.
Thanks. So, I think the clinics, we only crack open a vial, and there's usually 11 in some doses. We only crack it open if there's someone available to vaccinate. So we're not discarding it. If at the end of a vaccine clinic for our employees, there's a handful of doses left, we go and actively find people. So we see someone that's not already on the list, that's a patient-facing employee or something, and we get that in their arm. We're not wasting our supplies at any rate, from what I can see, and we're doing everything to maximize what we've got, including if there's, the extra dose that you've been seeing in the Pfizer sometimes. And could I steal Hope's question, and then I promise I'll give the time back to everyone else, Jeff?
Yeah.
So Hope had a question. Why do we build vaccine clinics? Did you hear correctly? Why not use stadiums or large facilities? So Hope, great question. The answer is we are actually doing just that. So like the dome is being stood up for a large vaccination clinic through the county. We're not necessarily standing up clinics per se as like a building that we're already using. We're doing drive-throughs. We're setting some of those up for the community-based vaccines at Rochester Regional. So we're trying to use our existing space as well. But there's definitely the dome. I think there's a few other places in the county as well. So trying to use that capacity that you just mentioned that's being underutilized currently.
Thank you. You know, I'm going to go back to John for a second. If you're still listening, John, we've left you for a while, it seems like. So, you know, we have these two vaccines that we're familiar with, Moderna and Pfizer. And those are the ones that we're seeing here in the US right now. And we know that coming soon, because they're in their last stages, are AstraZeneca, Johnson & Johnson, and Novavax. And we expect the dosages overall to ramp up. And so the US has given, or is already, has the rights to 100 million doses of Pfizer. And they've just recently purchased 100 million more. So that brings them up to 200 million Pfizer doses. And they have a contract for 200 million through Moderna. And all of these should be supplied by the summer, by early summer. But now you've got 3 more coming out soon. So we're at the infancy stage of this, right? We're still pretty early when you're looking at those kinds of numbers. So, you know, what should we expect to happen to the supply chain going forward? I mean, things have been built, things have been put in place. Is it going to get smoother as we go?
Well, I think it's a great question. But before I get to that, I just want to focus on Richard Doolittle's question about distribution. Why weren't we working this on the summer and the fall? And that was my point up front, that the distribution network, the website, the phone numbers, all of that stuff should have been handled back in summer and fall, not now. So to get back to your question, Jeff, I have a feeling that the supply increasing is going to be a positive thing. But on the flip side, I mean, if we're having trouble giving out the doses that we have now, if we have the websites crashing, I mean, I can't believe all the questions in the chat about people not knowing how to schedule an appointment. I mean, this is all part of where the planning really never was developed. And we had news out this morning that the Biden administration said that looking at the previous administration's plan, it really wasn't a plan. So Jeff, if we get millions and millions of more doses out there, okay, again, what that means is that it's distributed to the health systems, to the pharmacies, to the states, localities. But then the issue that we've been talking about is how do you get that into the arms of people? And there was a question in the chat about why aren't we using pharmacies? Well, I'll tell you an example. I know that the nursing homes are hooking up with the pharmacies to try to get the staff and their residents with the shot. And that many times the pharmacies keep delaying these events because they can't free the pharmacists from the pharmacy. It's not like you have a roaming band of pharmacists out there that are just going out and giving shots, just like the points that Dave and Balazs have talked about at their healthcare system. They just don't have people waiting in a break room to give shots at clinics or to the employees. I mean, where do you reallocate these resources from, whether it's the money, whether it's the staff, or whether it's the facilities?
I mean, in our case, we are volunteering. I mean, I'm going to go and give shots, next week, Wednesday night, because that I have a little time, and we are doing it actually in honor of one of our own partners who died of COVID. But yes, we need to. This is a volunteer effort. I mean, obviously, we use people to employ them that we employ and redeploy to do this. But when the ICUs are full, the floors are full, we had to change our practice from regular offices to telemedicine, which is the biggest change we have seen ever in healthcare. That we just did it on the fly in 2 months this last year. Those are really, these organizations are really stretched to their limits, and this is just one more thing to do. But again, that has not been the rate limiting factor, getting those volunteers or people to actually give the vaccine. We can do it. The one thing is that I think is important to understand that this is an unprecedented crisis, and we did some parts of it very well. Developing and approving the vaccine in 10 months was a fantastic thing to do, and the only way it was done, that things were done parallel, that normally is done in a sequential manner and takes 10 years. We did it in 10 months because we started producing these vaccines even before the phase 2 trial started. But as we pointed out, the distribution part, the entire plan was not a plan, and the weakest link in that chain was distribution. But another very important weak link in this chain is reporting. How do we know that those vaccines were given? People can go to pharmacy or B or C or who is going to schedule it, and where is the central database that we know who's actually vaccinated? What we learned as people improvised that our hospital was listed on statewide television of being a very low performer in giving out vaccines. And that was because of data problems, that we are reporting our data in multiple ways, and some of them just doesn't stick, it doesn't go through. Sometimes there are alternative reporting pathways. And the overall organization or structure where this data, who was vaccinated and by whom, and who is still outstanding, that really doesn't exist in this, in this federated healthcare system that I mentioned. And that is something that we are building with the state and ourselves, participating in and fixing the data sources and the health information exchange networks in unprecedented speed to make this happen. And just one positive thing that's going to happen from COVID, those investments that we made in health information exchange is exchanging information with the state back and forth, the video visits, and many other things that we did during this crisis to deal with COVID. Many of those investments will pay back long-term for our healthcare system and will provide long-term benefits when the pandemic is going to be history. But right now, these are crises, and again, there are many reasons. We can go them one by one, but I think one thing is very important to understand is giving the vaccine is important, but in order to know where we stand and to figure out what the gap is and who else needs to be vaccinated, that requires reporting. And I don't know, I don't want to dominate the discussion, but the reluctance is something that we can discuss if you want to come back to that topic.
I do, and actually, there's a question on the side I'd like to bring up, and I'm not sure who the expert in this, so I'm going to ask it and see if we have somebody that has the knowledge. Leslie Weber states that what a great job has been done so far and how impressive it's been, but then says that the actual vaccine does not protect against actually becoming infected, and therefore people can still be infected and pass it on. At least that's what she's hearing. If this is the case, it is very dangerous not to emphasize this because people think of the vaccine as protecting them against getting the disease. Can we get any information on that? I mean, isn't that the understanding that it does actually build your immunities to fight off the little bit of, isn't that what it is?
So when you think about the vaccine is a piece of mRNA. mRNA is messenger RNA, and it doesn't go into the nucleus of the cell, but it goes into the cell itself, and you then manufacture a protein that's coded by that mRNA. And that protein you're manufacturing is an analogous piece of protein to the spike protein. So you've seen a virus with the little spikes. It's an analogous piece of protein to the spike protein, and you develop antibodies to the spike protein. So then if you should get inoculated with the virus, if you should get exposed, someone coughs, you're in a room, you touch something, then your body will have seen and have a immunogenic memory to that spike protein. So you should kill that virus before it can infect you. I don't think there's good data out there to tell you exactly what's going to happen, but most people believe that the way this works is that you will not become infected, or if you do get infected, you'll have much less of a disease. Exactly what we should do, I don't think we should be cavalier or presume just because we've been vaccinated that you shouldn't be cautious and use your PPE and mask up and wash your hands. But I believe the potential to get compromised and to spread that to someone else is dramatically lower after both doses of the vaccine.
It's just I think the correct statement, there is no data to prove that this is the case, but the lack of data to prove this doesn't mean that this is not the case. And I think that's a very important distinction.
Right.
We have not studied this, but obviously all these studies were done in 30,000 people and so on. Right now we are vaccinating millions, and that's why reporting is so critically important. We need to know who is vaccinated. We need to know what happened with those people who got vaccinated. And I think that information, to gather the information of who got vaccine and what happened after that, and following millions and millions of people, will be the way to answer that question that you just posed. Can you still catch and transmit the disease if you get vaccinated? Now, we know for a fact that you can catch the disease. There are still, even though it's an order of magnitude less of the risk, you can. But the idea that you're going to catch the same number of disease, you're just not going to have symptoms and going to spread it, there is no reason to believe that at all. But there's no data to show what is the level of protection for that. But again, a flu vaccine is 50% effective, and we still use it, and 50% effectiveness is a very good effectiveness in terms of managing the pandemic. It may not be that level of protection for the individual, but for the population, it is. So even if we just decrease 50% those infectivity, that would be very good. But as Dave explained, I expect that it's going to be a much higher level of protection from doing that. We just don't have data. And again, we can speculate, but I think what is critically important is that we remain, what we actually proclaim, it should be supported by facts. And we just don't want to make that statement until there is data to prove it.
So what you just said brings up something I was going to talk about anyways, and that's the side effects, right? And the populace, the public will anecdotally assign all kinds of things as side effects. Because something happens to somebody, that will get out and that will be a side effect of the thing. We know that's not how it works scientifically, but it is a concern. There's a risk of the public misinterpreting things. Every day in the US, there's 110 cases of Bell's palsy that are unassigned, that are unclear what caused them. There are 274 cases of Guillain-Barré syndrome and not clear where they came from. And many of those could be associated with somebody who had a vaccination. It can happen with a heart attack that's unexpected after somebody's vaccinated. So am I right in understanding that there is some kind of tracking of the side effects and it's being done through the federal government or the CDC? Is it the VSafe syndrome or not syndrome, the VSafe process or what is that?
Yeah, it's the VSafe app, yeah. Yeah, the CDC have that. So, but again, it's all voluntary. And this is the other thing that we mentioned. Nobody has full control over, the federal government does not have full control over what the state does. The state does not have full control over what the hospitals do, and regulations change. And we have no full control over our employees, as we pointed out. And by the way, there are many healthcare workers who are not even employed by us, and we need to track them as well. So the same way, we have no way to enforce people to report their symptoms, but still we're going to have lots of reporting based on that. But not only people's self-reported symptoms are relevant. What is important is how we gather this data nationally, because our health system, our electronic medical record systems that we spent 10 years to build now have this data. It needs to exchange the data, and somewhere we're going to need to aggregate this data. One of the discussions that we just had right before this meeting was one of our medical directors presented a software. Again, I don't want to mention any specific company, but our EMR vendor created this software solution that actually gathers data from all of their clients, and they have 100 million patient data points, and we can monitor what happens to those patients, and we can correlate the vaccination with heart attacks and Guillain-Barrés. And there's not going to be a one-to-one connection, but if something becomes twice as frequent or 50% more frequent than it was without the vaccine, then we're gonna have a spike, and we're gonna have this data point, and we can start assessing that. But the problem is, obviously, you mentioned there are hundreds of Bell's palsies and Guillain-Barrés, and then if people get it after the vaccine, those individual cases create those individual, the connections which are not scientifically proven, and there's no post hoc ergo propter hoc thinking is obviously scientifically wrong, but people who are affected, they are emotionally looking for something to blame it. And that spreads like wildfire in the age of social media. So that is something that's why I emphasize that we don't want to make any statement that we cannot prove with data. And that is why, even though biologically it makes sense that people will not spread the virus after they get vaccination, we don't want to say that. But at the same time, we don't want to make any statement about those side effects that may circle on social media. The only thing that we actually see, there are allergic reactions, which is true, but penicillin causes a deadly allergic reaction every 20,000 kids when they receive it. Have we banned penicillin? No, it saved millions and millions and millions of lives. the frequency of severe allergic reaction is much lower for the vaccine.
Okay, and actually, you get to the fact that the side effects you're seeing are very minimal. You mentioned allergic reaction or anaphylaxis, and I think I saw that there have been 24 cases or some very low number among millions of doses. So it is possible, but very minor. Really, what we're talking about is soreness in the arm after the first shot and possibly feeling ill after the second shot are the most common side effects. That's correct?
That's correct. Yeah, the second shot is you feel that the next day. I can tell you from experience because, again, I work in the ICU, so I got vaccinated relatively soon.
So I'm going to go back to John a little bit, and we're going to talk a little bit about what Hope's question was. Hope was asking about the poorer countries in the world and how are they dealing with the vaccination process. And I mentioned earlier there are 16 different international vaccines that are in phase 3 right now. There's the Sinovac from China that's out there and is being used in Indonesia, China, Brazil, a much lower efficacy, somewhere around 50% is what the numbers are saying now. There's I don't even know what the status is of the Russian vaccine, the Sputnik 5, that was one of the first that came out. But there are many others that are in the process. But as a result of what's happening in the world, just like in the US, the countries that are developing these, where these are happening, are buying up all the doses. That's what's happening. And they're using the resources in the places that have the resources. This is one of the clashes that the WHO had with some of the developed nations, saying that we've got to find a model that helps to take care of the whole world. On the other side of this, there was actually a write-up, and Matt mentioned a write-up in the New York Times mentioning how few doses had gone to some countries. I saw a write-up on Nigeria, and it mentioned that in Nigeria, where they're getting not many doses at all, they also had a 0.6 per 100,000 caseload. So in other words, they had a much, much lower caseload of COVID. That could also be because they're not testing very much, which is a question I would ask. But it's interesting. Not every country is in the same position. And so, John, talk to us about the international supply chain and how this works and what we can expect going forward.
Sure. First, Jeff, I want to give a shout out to my present and past students, if I can do that, please. But I mean, take a look at normal supply chains for third world countries. I mean, they don't have refrigerated transportation. They don't have the type of healthcare systems that the more developed countries have. So, I mean, you're taking what they already have, which is a weakness, and you're compounding it by having the Moderna and Pfizer vaccines having to be kept at really super cold temperatures. And even in rural America, a lot of healthcare systems don't even have the freezer systems to handle it here in America. What do you think it's going to be like in Africa and Asian countries? An example you were talking about, wealthy countries buying up batches. Canada has purchased 600 million doses of vaccine. There's not 600 million Canadians up there. And so they're actually just starting right now to free up future supply, not present supply. And so that'll help, in that probably 3 to 6 month time frame. So we have the international organization COVAX, which the US does not belong to, but potentially under the Biden administration, we will. And that's an organization that's trying to buy, as a group, vaccines for the developing countries, for the lesser developed countries also. So there's an attempt to try to at least cushion some of this inequity when we're talking about these international supply chains. But again, you take a look at countries like India, very poor healthcare systems in many of their regions, with many of the people living in rural areas where it takes a long time to get to them from central cities or rail lines or ports or things like that. So what some of these countries are doing is they haven't purchased the Moderna and Pfizer vaccines because of the cooling issue, but also because of the 2-dose issue. What they're waiting for is the AstraZeneca and potentially Johnson & Johnson, which will be one shot that can be kept at what we'll call cooler temperatures, not freezing cold temperatures. The trouble is many of those doses that haven't even been produced and approved yet are already sold. So they're way behind the curve as far as when would they be able even to get some supply, and when would they be able to distribute some of that supply and get the shots in the arms.
And also, John, those doses from AstraZeneca and Johnson & Johnson are expected to be much more expensive, is my understanding. which is going to be a challenge for those countries. But you know what happens in an imperfect market when supply doesn't meet demand and there are challenges this way is a black market develops. And believe it or not, there's also a vaccination tourism market that's kicked off now. People are actually traveling to locations where they can get shots. And this is not just happening with people coming to the UK and to the US. This is people within the US going to different states where they have access more quickly or more readily. It's a crazy environment that there's no control for right now because nobody planned for this kind of a reaction. This is what happens.
Right, Jeff. And I mean, you just take a look at what Governor Cuomo said a couple of days ago, that New York State is going to try to buy vaccine directly from the manufacturers to try to increase the supply. And just anecdotally, I have been, like a lot of people, trying to get online to get an appointment. And around here, there's no appointments available. But I have an appointment in the North Country in 2.5 weeks. You know, I haven't decided that if I'm going to make the drive, it's 4.5 hours to get there or not. But I mean, so what's happening is this is inefficient, Jeff, because the opportunity cost of all of this scrambling around and spending all this time and spinning our wheels, it's costing us resources.
A little bit scary. Okay, I'm going to try and catch up with some of the questions here on the side. And I've got to scroll back a little bit through some of these. One question was about exporting versus importing, John, and if you see that becoming a market in the near future. So, you know, if the US catches up and you just mentioned Canada, maybe Canada becomes an exporter. But is that, do you see that coming where the US will maybe import vaccination from other places if they're available? Do you see them, when we get on the other end of this curve, maybe starting to export vaccinations?
It really all depends on, you know, the country's manufacturing capability of vaccines. There's very few countries that have the ability to manufacture vaccines. You know, a country like India has 2 massive companies that are right now producing vaccines for an Indian pharmaceutical company, but also for other pharmaceutical companies. So it really depends on manufacturing capabilities. Here in the US, we have pretty good manufacturing capabilities for the vaccines, and all the companies have been ramping up. Pfizer, Moderna, Johnson & Johnson, a couple of the others that are a little bit further away from approval, they've been putting hundreds of millions of dollars into facilities. They're building up supply chains for the syringes and the vials and the needles and all those other things and the components that go into the vaccine. So I don't know if the US would necessarily be an importer. There's a good possibility that we'd be an exporter, because if you take a look at the numbers, within the next 9 to 12 months, if things go as planned, we'll be producing way more vaccines than we need for the 340 plus million Americans that we have.
Thank you. Okay, now I'm going to put the RRH people on the spot, and I apologize for that. We're not going to hold you to this. We're not going to publish this, but I'm curious for your personal take on when you think the US could reach herd immunity, could reach some form of a number that we're in a better position. And what timeline are we talking? Because people have talked for a long time about when will we be over the hump, right? When will we get to a spot where they call it the new normal, right? Get back to something that we're used to or more comfortable. And I saw one of the chat comments on the side talking about the WHO saying we're going to need to mask and social distance well into 2022. I'm just curious what your take is on that. Do you see those dates being realistic? Do you see us being vaccinated this year?
Jeff, I think it also depends on, I mean, there's still, you got variables you can't control, right? How much supply we've got, what's the public perception of it? You mentioned, you know, under 55, like, what was it? Somewhere under 60% wanted it.
Between 45 and 64, 52%.
Yeah, so I mean, you have all those variables too at play. So assuming everything changes, everyone takes it, you know, you can make a lot of assumptions there, but I think we just don't know, because it deals with, and I hate that masks and that vaccines were so highly politicized. I mean, I feel like it should be about getting good information out there to people. As Balazs said, you know, here's what we've seen. We don't have science on it yet. So again, we don't want to make information out there that could be taken the wrong way. It's establishing a trust in all of these and getting it out there. So I hate to, you know, answer your question by not answering it like a politician, I guess. But the answer I would give is I just don't know, because you have too many other variables at play behind the scenes.
So Matt, I think you said that. And I think one of the things that we've learned from this is how to be responsible when we're in an unprecedented public health crisis. And do we know exactly when we're going to get enough herd immunity based upon the infectivity or not of this virus, based upon all the factors we're just talking about? Not all pieces of the supply chain are intact because, once again, we do have an unprecedented public health crisis, and we have more than one. They're overlapping. When we're now trying to understand how to mass vaccinate the entire populace of the US at the same time, we are just coming down from, hopefully, our second wave peak. And in many of our areas, the second wave peak was 2 and 3 times the magnitude of the first wave peak. So the resources that you're straining are being strained on multiple fronts. But the other thing is, how can we be responsible in a time like this? And one of the things I want to highlight, when you look at the influenza trends, we're being very responsible right now because of masking and social distancing, because of COVID. We're seeing almost no influenza right now. So that's giving us some insight into how, take away the politicization of all of this, being responsible in the face of a public health crisis is only going to help us reach that point in time when we're going to achieve the type of herd immunity that we know will bring us back to where we want to be.
Yeah, and again, just the last thing is when, we hope that it's going to be 2021, but it's probably going to be late. I mean, the aspirational plan now is to get 100 million vaccines in 100 days. Obviously, that's only 30% of the population or so. And the original mathematical model said that for this vaccine, with the infectivity of COVID, we would need about 70%, 75% of immunity to reach herd immunity to stop the spread of the virus and have the pandemic to finish. At the same time, we all read the news about viruses or virus variants that are more infective than the one that these models were built upon. And it's quite possible that we will need 85% or 90% immunization rate in order to have the pandemic to subside. So I think realistically, if we keep up that speed and we can vaccinate 1 million person per day, then that's going to be until to the end of 2021. And that brings back the reluctance issue. Is there are lots of reasons for reluctance, and again, there's in the individual level. Obviously, the older and sicker you are, the more benefit you get from the vaccine. The side effect of the vaccine is probably the same. And if every 1 out of 10,000 people have some serious side effect of the vaccine, which actually is not the case, it's much lower than that. But in that case, if your chance of getting the disease and dying is 1 to 10, you have a very, very strong reason to get vaccinated if you're 80 years old. But if you're 8 years old, your chance of dying from this disease is less than 1 in a million. So in that case, it would be hard, scientifically and ethically, very, very difficult to say that we want to vaccinate those young people. So this is something I think it's going to evolve as we learn more about the vaccine, the effectiveness, the infectivity. And what is critically important, again, is to get good data of those first millions of people that we vaccinated, because that's hundreds of times of more data that we have from the vaccination trials. And I think that's going to be really the answer to get, to when this is going to end.
And Balazs, Dave made a point, also, side effect versus adverse reaction. So
Yep.
They're two different things.
I think, Matt, it's really important. So when you talk about side effects, so if you get a vaccination, you have a sore arm, or even if you have a fever and muscle aches, myalgias, that feels like a little bit like the flu, that's a side effect. And honestly, when I think about that side effect is actually an indicator that your body is immunologically reacting favorably to the vaccination and producing those antibodies against the spike protein that you want in the future. In contradistinction, an adverse reaction would be like a Guillain-Barré, a neurological reaction, or an allergic reaction. And as Dr. Zsenits said, the data that you would get that would inform you in advance about what the proportion and risks of the side effects versus adverse reaction, they come with the historical ways of studying these type of new medications or vaccination over years and years. In contradistinction, the drug companies did something miraculous. They got it out in 10 months. And so 10 months from now, 20 months from now, I think we're going to have a robust database of information from everything we've done that's going to tell us exactly what the true incidence of all of these will be. But just be thoughtful. If your side effect is a little bit of a flu-like illness, you might want to welcome that side effect.
I will.
And actually, Balazs, you mentioned a minute ago also, Dr. Zsenits, that the potency is very important, right? And how much of the dose, and there's some discussion, we didn't talk about this yet today, but there's some discussion in different places. I think England is looking at maybe presenting to patients in a different way, right? Not giving 2 doses of a full vaccination to each patient. And there's some consideration that may be quite effective, especially among the most healthy people. So that the people in that range of 18 to 44, whatever the number was that they came up with, might get a half dose twice, or 1 dose that's only a single dose of what should be a 2-dose practicum. Can you tell us a little bit about that?
Yeah, so what we mentioned, herd immunity means that people are protected enough not to catch and spread the virus. Now that comes back to the question that we discussed earlier, that does the vaccine actually protect you from getting infected and spreading it? And we assume it does. Obviously, if it doesn't, you cannot reach herd immunity. But we really expect it does. We just don't have the data. So if it does protect you from spreading the virus, vaccinating young people whose chance of dying from the disease is 1 in a million is not really for their own personal benefit, but it is to protect the population and ending the pandemic. And for that, as we pointed out, many other vaccines has only 50-60% of efficiency, but that's good enough. That's good enough to protect the population, even though it only gives you 50% protection as a person. But again, that is the data that we need to understand. If our goal is to reach herd immunity and vaccinating twice the number of people with less effect of individual protection, because giving a single dose only brings you about 60-70% protection versus the 95 to 100% protection of having 2. But if that is our goal, then a strategy of giving single vaccine to many people, it would be reasonable. But it's only reasonable if 2 things happen. Number 1, you can actually vaccinate. It's one thing. You need to vaccinate enough people to stop the spread and achieve herd immunity, and that depends on the fact whether or not vaccination stops spreading the disease. And number 2, it requires the proper number of people to accept the vaccine. And that is why communication and addressing reluctance is so important. And reluctance may come from, what is my level of risk and protection from getting the vaccine versus, we mentioned African Americans earlier, is the traditional, I think we can say abuse that African Americans receive from the healthcare system. And even it was many decades ago, we haven't completely reversed that trend, even though we are working on it, and we have been working on it for many years. And again, the politicization that Matt mentioned. So we need to overcome that to reach the proper number of people. And also we need to make sure that this strategy works, because the vaccine actually stops spreading the disease, not just getting you sick from it. So that's why I think that strategy is a little premature, but definitely it would make sense in the proper scenario.
So we're at 1 o'clock right now. Does anybody on the panel want to say one last word? You don't have to, but if you have something you wanted to get in that you didn't yet, now would be the time.
I just want to talk about, just real quick, some news that came out today, 900,000 more unemployment claims. The job market is stalled, and a lot of it is due to this vaccine issue. I mean, the quicker that we get the vaccine out, the quicker the economy comes back, and we keep pushing the economic recovery back because of the vaccine issue.
It makes you wonder, John, if you go back to we're not there, I understand, but if you go back to a Great Depression type of a mindset, where the government said, we're going to employ people doing things that need to be done, that this is one of the ways you could do something around that, right? You could find a way to help create that system that we need to make this happen more efficiently. Okay, thank you very much. I want to really, really thank you, because what a great opportunity. We could probably do this for 3 hours and we'd still have questions coming in. I really appreciate your time and effort. Thank you, Dr. Krusch. Thank you, Dr. Zsenits. Thank you, Matt Phillips. Thank you, John Striebich. Very enjoyable. I know we didn't get to all of the questions, so if you've got questions that we didn't get to that were important, you can send them to me and we'll try and get responses back to you. We really appreciate your time and effort. Today was really fun and interesting, and pay attention. We'll have something new out next month, we think. So thank you very much. Everybody have a great day and be safe. And
Thank
get
you.
vaccinated. Get vaccinated, everybody.
Yeah.
Yes.